So atrial fibrillation is a pandemic, is one of the chronic medical illnesses that we have in addition to diabetes and hypertension. Atrial fibrillation is now added to the list. The prevalence is increasing as people age and accumulate chronic risk factors like diabetes, hypertension. 1 in 3 individuals have atrial fibrillation. And our area is underrepresented here, and I always say it's our duty to color the Middle East and supplement it with our own data from our own patients. And there's no better way to discuss this than this conference. Atrial fibrillation requires multidisciplinary team and specialists to treat those patients. What is atrial fibrillation? It's one of the most common atrial arrhythmias or cardiac arrhythmias that everybody will encounter: the cardiologist, the internist, even the surgeon and the ER physician. It is associated with high degree of morbidity or mortality, higher hospitalization, and complications. So how do we diagnose it? We still need at least 30 seconds of a 12-lead ECG or rhythm strip to diagnose atrial fibrillation. And as we all know, it is an irregular atrial activity. What causes it? Everything that we know can cause atrial fibrillation, starting from age, genetics, gender, and all the chronic risk factors: diabetes, hypertension, heart failure, coronary artery disease, and very importantly, obesity, obstructive sleep apnea, COPD, and any inflammatory disease. I'm going to skip that, but the last evidence that we have is from Professor Zbaid on the ER admission or presentation in patients with atrial fibrillation. And I think now we've moved along from ER presentation to in-hospital management and outpatient management of atrial fibrillation. So let's talk about atrial fibrillation in terms of causes. Recently, the Canadian guidelines in 2020, they proposed an idea that atrial fibrillation can be primary or secondary. Secondary meaning secondary to an inflammatory illness or acute critical illness. And the American guidelines also joined that, and I'll present it to you in a very nice graph later on. Terminology, what we want to use is paroxysmal atrial fibrillation if it lasts less than 7 days, persistent if it's more than 7 days, long-standing persistent if it's more than 1 year, and permanent if there is no intention to pursue rhythm control strategies. What we don't want to hear is chronic AFib, because it means that discussion for rhythm control strategies is either not discussed or we're not aware of that. What is valvular atrial fibrillation? Any patients with atrial fibrillation and moderate to severe mitral stenosis or mechanical valve, and this just dictates management or what type of anticoagulation you can use. Why does atrial fibrillation happen? So there is an electrical and mechanical or structural remodeling that happens in the wall of the atrial myocytes. Deposition of fibrosis in the body of the atrial musculature can cause initially electrical remodeling that will cause the foci that will precipitate or starts the atrial fibrillation circuits, and initially it will evolve into structural remodeling. And as is well known in the field of electrophysiology, the main, at least initially at the beginning of the disease, the triggers are always from the pulmonary veins. So the higher the burden of atrial fibrosis, the higher the chances of developing atrial fibrillation, and this was studied in cardiac MRI trials. So atrial fibrillation usually starts as paroxysmal bouts of atrial fibrillation that can cause patients to be admitted to the hospital, and over time, patients will accumulate non-modifiable risk factors. They will age over time, and they will develop hypertension, diabetes, and what so on. So the more risk factors they will accumulate, the higher the risk of developing persistent and permanent atrial fibrillation. And 15% of those with paroxysmal atrial fibrillation will go on to be a persistent atrial fibrillation within 1 year. And we don't want that to happen, and we'll see why. So reversible or provoked. So recently, actually this year, it's hot off the press, so the American Heart Association, also in alliance with the Canadian recent guidelines, declared or described an entity of acute atrial fibrillation. So all cardiologists, you're either getting a troponin consultation or atrial fibrillation. So any patient who gets admitted with pneumonia or infection or sepsis, they are at risk of developing atrial fibrillation, and sometimes it's difficult to know what to do with these patients. Again, you manage the acute illness, And you discuss the need for rhythm control strategy only in case of hemodynamic instability. Anticoagulation is decided based on the CHA2DS2-VASc score, and what's important is follow-up of these patients if they go on to develop persistent or further episodes of atrial fibrillation. In the clinic or in the ward, so most patients don't have actually symptoms of atrial fibrillation, or they have vague symptoms that are not traditionally palpitations, like fatigue and shortness of breath. These are actually the most common symptoms that we see in clinic. We can try to classify and make it more standardized in our clinical notes, but be aware that not all atrial fibrillation is described as palpitations. European Society of Cardiology made it easier as ABC to help us manage atrial fibrillation. And as I said, because of the complicated or underlying predisposing risk factors, it needs more than cardiologists and electrophysiologists also managing the rest of the cardiovascular risk factors. So we'll go quickly over these. A stands for anticoagulation and avoiding strokes. So we need to assess the risk for stroke by using the CHA2DS2-VASc score. And just to emphasize that MI, peripheral arterial disease, and aortic plaque should be incorporated in the CHA2DS2-VASc score. And this score, it's not a lifelong score, so every year there's a risk of stroke of 3% for patient with CHA2DS2-VASc of 3. So every year the patient will, it's not a lifelong or lifelong risk of stroke, it's actually a yearly risk. So who do we anticoagulate? Those with CHA2DS2-VASc score of 2 in men and 3 in women. 1 in men and 2 in women can be considered. Canadians made it easier. Everybody above 65 years of age can be anticoagulated, or the other traditional risk factors of stroke, hypertension, heart failure, and diabetes. Those with only coronary artery disease can be only on antiplatelet therapy, if they don't have other risk factors, obviously. I think NOAC changed the way we manage atrial fibrillation, and we all prescribe them regularly in daily practice. But what's new, or what's happening in patients with renal failure or dialysis? So just to go back, we know that all the NOACs are excreted usually or predominantly through the kidneys. Apixaban, however, mostly excreted through the hepatobiliary or the GI tract. So recently there have been a lot of interest in studying the effect or using apixaban in patients with chronic kidney disease, and specifically on dialysis in 2 trials. The one is the renal AF trial that was mostly in the US, and this was also supplemented by pharmacokinetic studies. They used the 5 milligram BID and the 2.5 BID. And it was shown that apixaban is non-inferior actually to warfarin in this patient population. This was a very small study, so it was not powered to detect significant or superiority, and it was terminated early because of a low recruitment rate. Similarly, the Excedia FNET trial also was mostly in Europe. This is not a randomized control study, but also showed the same benefit, but they only decided to use the 2.5 milligram BID of apixaban. So guidelines did not change tremendously yet. The American guidelines decided to go for that change earlier, only based on observational studies. So this was before the randomized control trial. And they recommended that apixaban can be used as an oral anticoagulation for patients with patient on dialysis. And this is one of the meta-analysis that they based their recommendation on, the 2.5 and 5 milligram BID. So next is rate of rhythm control. So why do we care about restoring sinus rhythm? So we heard all the talks today, heart failure, mitral regurgitation. So atrial fibrillation is a cry for help. So it can cause atrial myopathy, it can cause mitral regurgitation, and heart failure. And there is evidence that early on, intervening and restoring sinus rhythm, there might be actually an improvement in ejection fraction. And also this slide was shown earlier, atrial mitral regurgitation secondary to AF can cause significant symptoms. And it can be in HFpEF and in HFrEF as well. So when do we refer patients for rhythm control strategy or atrial fibrillation ablation? In patients who are symptomatic despite antiarrhythmic therapy, and this is consistent throughout all society guidelines, and patients with persistence as well if they are still symptomatic. Patients with LV dysfunction, they have the most benefit and mortality benefit as well. In my opinion, it's no longer rate or rhythm control strategy, and the old AFFIRM trial had some caveats with a lot of crossover between rhythm and rate control. And also in the on-treatment analysis showed that there is significant benefit on patients who are in sinus rhythm. The last 2 to 3 years showed a plethora of trials comparing antiarrhythmic therapy and ablation strategies. This is the eStaffnet trial that basically showed that early rhythm control, no matter what strategy you use, antiarrhythmic drugs or ablation, was associated with improvement in the primary outcome, which is cardiovascular death, stroke, or hospitalization. Just to keep in mind, this is not an ablation study. This is actually almost only 20% of patients got ablation. Everybody else got antiarrhythmic drugs. So, and then we move on to ablation studies. Early AF studies showed that intervention early for patients with paroxysmal atrial fibrillation improves outcomes, and this was mostly a cryoablation or ablation with essentially freezing the cells. I'm going to move fast because I have something else to cover, and this is the same concept but using radiofrequency ablation. So this is another study that showed basically there's no difference between heat or cold in terms of ablation in achieving the ultimate outcome, which is improving event-free survival and asymptomatic or no atrial fibrillation recurrence, at least in 1 year. All right, so which patients are ablation candidate? All symptomatic patients who failed antiarrhythmic medications or were cardioverted. Patients with heart failure, yes, they're the best candidate for that, but need special attention. Those with severe left atrial dilatation, and those with obesity and sleep apnea. What are the goals of ablation? So honest discussion with the patient needs to take place. The goals are restore sinus rhythm and maintain it. Better quality of life and being symptom-free, and also decreasing the burden of atrial fibrillation. How is this done? It's a procedure that's done in the cath lab under mostly general anesthesia, but can be done in some institutions under moderate sedation. It's usually done through the femoral venous access through a transseptal puncture to reach the left atrium, where we can study the left atrium using electroanatomical mapping to limit fluoroscopy initially exposure. So what we do is basically isolate the pulmonary vein, which is in most cases the trigger of these atrial fibrillation. So this is a study, this is NCDR data from the US. It's a national registry of all atrial fibrillation in the country from 2013 to 2018, academic and non-academic center. And this is just showed complications that can result from atrial fibrillation ablation are usually minimal. And I'm just highlighting the most common ones, or the ones that we worry about, is perforation and hemopericardium, phrenic nerve injury from ablation, or cardiac tamponade. Is there any mortality benefit? So yes, quality of life is important, but in patients with heart failure, there's actually a mortality benefit up to 16%. So these patients, I think, they are neglected in our country. And this was greatly reported in the CASTLE-AF trial. So we want to restore sinus rhythm. AF ablation is superior to antiarrhythmic drugs, and atrial fibrillation ablations are safe procedures and performed in most institutions. Do we have anything new? Yes. So in the EP world now, the new kid in the block is another modality of ablation, which is electroporation. So in addition to having radiofrequency ablation and cold or cryoablation, there is electroporation, which is essentially delivering a high-intensity electrical current to the cells, creating pores to the point that there is irreversible damage and causing cell death or apoptosis. So every company, there's a race to develop the most sophisticated catheters. We have some that are readily available, and a lot is coming on the way. So electroporation is used in the same technique that is used in the pulse field ablation, or PFA. So we have this FerroPulse. These are some of the Medtronic or Affera catheters, and this is also, we're still going to hear about it in the upcoming years, the ultra-low temperature cryoablation, which is colder than the catheters we have. So a lot of trials reported they were first in human studies regarding the ferropulse or the pulse field ablation using this kind of catheter, which goes into flower and basket. It showed significant safety and also good outcomes in terms of after 1 year. So we have 3 trials. There were small trials, 40 patients each, that showed benefit of PFA. Again, there are more catheters that are combining even PFA and radiofrequency ablation to try to give the physician or the electrophysiologist all the tools that they need in one catheter instead of using multiple technologies. This was recently described or published as a late-breaking trial in ACC this year, which is the pulsed AF. Again, it used the pulse field ablation catheter that's in a circular manner to isolate or ablate the pulmonary vein, with monitoring with ECG after a maximum up to 12 months. Again, showed significant benefit. Why do we need another ablation modality, you might ask? Do we need more tools to play with in the EP world? So this is getting attention because using cryoablation or radiofrequency ablation, there's no cell selectivity and there is potential injury to the esophagus or the phrenic nerve, which passes close to the left atrium. In pulse field ablation, they showed that there is actually very limited or very minimal, not even reported esophageal injury or phrenic nerve injury. So PFA provided less complication rate, although they're already less than 1% to start with, but even lower complication rate and faster procedures from skin to skin. All right, a few words about post-ablation. We need to continue anticoagulation guided by CHA2DS2-VASc score. Antiarrhythmic drugs are usually continued up to 3 months. It depends on the institution, but this is what we call a blanking period. And then maintenance or documenting maintenance of sinus rhythm is assessed depending on the operator, either by ECG at follow-up or by Holter monitor. What about patients who are at high risk, high bleeding risk? We should calculate Has-Bled score in every clinical visit we see the patient. And we know that the medications we like to use, although they're very efficacious and some are superior to warfarin, but they come with risk of bleeding as well in patients who are predisposed to that. But we should keep in mind that not every bleeding risk is permanent. If there's a reversible bleeding risk, we should control that incident or that bleeding source and reassess the situation again. In patients who have contraindication for anticoagulation, there is some non-drug options that might be considered in these patients, like left atrial appendage closure devices that are classified as Class 2B in the American and the ACC guidelines. We know that the left atrial appendage is responsible for as an embolic source of stroke in about 90% of patients, and this is what we want to try to avoid. There are many kind of closure devices. They're the most common ones. Watchman and the Amulet. Watchman went through several studies that resulted in FDA approval in about 2007. So we have the PROTECT AF and the PREVAIL studies. In addition, so these studies, the previous one, they actually included patients who have no contraindication to bleeding, but the latest trial, where is it? I'll show it later. The Pinnacle showed actually patients with high risk of bleeding. So studies compared Watchman to warfarin. This study was the only one that compared left atrial appendage closure devices, Watchman and Amulet with the NOAC, and showed no significant difference in terms of their primary outcome. The study was not powered to just detect superiority in the stroke in particular, but the primary outcome showed no difference between these two devices. Similarly, there are some differences, obviously, among those two devices, specifically device-related leaks and device-related thrombosis. Some studies might suggest Watchman might have slightly higher degree of that. What do we do after we replace these devices? It depends on the device you use. Some patients might need short-term anticoagulation or dual antiplatelets. Yes, there are some more devices to come. Maybe we'll wait for them. And also comparison between the newer device, the new and improved Watchman Flex compared to NOACs as well. What else do we need to do for patients with AFib? Not just medication and ablation, and this is extremely important. Weight loss and obstructive sleep apnea management. Several studies showed that whether you ablate AFib or not, Weight loss of at least 10% reduces the burden of atrial fibrillation and recurrence, whether you ablate the patient or not, and in some cases, it reverses atrial fibrillation from persistent to paroxysmal. So weight loss is very important. And also treating sleep apnea. So my take-home messages is atrial fibrillation is the most common atrial arrhythmia or arrhythmia encountered in clinical practice. Early diagnosis and screening, even in the clinic, thinking about intervention and halting disease progression is crucial. Ablation is safe, feasible, available with evolving technology available in the country. Left atrial appendage closure is an appropriate option in patients with high bleeding risk, and lifestyle intervention are crucial in maintaining sinus rhythm. Thank you very much.